Okay, we're going to do Chapter 11, which is your high-risk prenatal care pre-existing conditions. We're going to talk about metabolic disorders, and the first one that we're going to talk about is diabetes. Diabetes is a very big disease that you guys are going to see not only in the mother-baby world, pediatrics, and also med-surg. So we are going to spend some time on diabetes. We're going to start on page 268 in your textbook. This is just an overview. Most of this you guys already know. It's really just a review as far as diabetes go. So when we have hyperglycemia, it results from the defects in our insulin secretion, insulin action, or both. Insulin is produced by our beta cells in the islets of Langerhans. It's in our pancreas. It regulates our blood glucose, and it also enables our glucose to enter adipose tissue and the muscle cells, which is used for energy. When we also have hyperglycemia, we have hyperosmolality of the blood. This attracts that intercellular fluid. Remember, I told you guys, fluid and electrolytes was not going to go away. That is the base foundation of your house and the base foundation of your knowledge into med-surg and all the other categories that you guys are going to learn throughout nursing school. So it attracts the intracellular fluid into the vascular system. This results in cellular dehydration, which expands the volume. So then what happens, or consequently, we have the kidneys increase our amount of urine, which we get polyuria, and that's one of the big signs of diabetes, if I can spell it correctly. So we have increased urine output, and then because we have the cellular dehydration and the increased urine output, we become extremely thirsty, and that is your other P, and that is your polydyspnea. So then our body compensates for that inability to not convert the carbohydrates into energy by burning proteins. This causes ketones in the urine. So when you are testing diabetic patients, the big thing that they're really looking for is ketones in the urine. So that's just a quick kind of overall review of diabetes. We're going to talk about a couple of different types. We're going to talk about gestational diabetes, and we're going to talk about gestational diabetes. So with gestational diabetes is written in the terms of GDM, gestational diabetes mellitus. It's any degree of glucose intolerance with the onset or first recognition during a pregnancy. Women are diagnosed usually with gestational diabetes need to be retested 6 to 12 weeks after they deliver their baby. Women who have gestational diabetes does not necessarily mean that they were a diabetic patient prior. They developed it once they became pregnant. They're at higher risk for becoming diabetic later in life. So some of the things that we need to know with diabetes is that glucose is the primary fuel for the fetus. It's transported across the placenta. Glucose crosses the placenta, but insulin does not. A lot of these moms will get insulin to treat the diabetes. They have a tendency to have hypoglycemia in the first trimester. And then towards the end, or in the second and third trimester, they become hyperglycemic. so their insulin needs become increased. So even though the insulin does not cross the placenta, around the 10th week of gestation, the baby begins to secrete its own insulin. So we talked about first trimester and moms becoming hypoglycemic. What happens is we end up having a rise in estrogen and progesterone. These are two very important hormones that you guys should have read in your summer readings. They stimulate the beta cells in the pancreas to increase the insulin production, which promotes peripheral use of glucose and decreases the blood glucose. So this is kind of our body's way of trying to compensate on its own. We just talked about the second and the third trimester that moms do have to have a increase in their requirements, usually about 18 to 24 weeks. It's a gradual increase in insulin need, but around 36 weeks gestations, it may double or quadruple the need of insulin that mom needs. Once mom goes in, she has her baby, placenta is delivered, quickly we have an abrupt drop in the circulating hormones in mom, cortisol and insulin, so she ends up regaining back her normal state of blood sugar level after she has her baby. And these are in the gestational diabetic moms, not diabetic mothers. Some of the things on your PowerPoint slides, mom's maternal risk of complications. Those moms who have poor glycemic control are at a higher risk for a miscarriage. Those moms who also have poor glycemic control are at a higher risk of having macrosomic babies. I brought this term to your attention in another PowerPoint. This is a term that's not going to go away. You're going to see it. These are the ones I said were those fat little scrunchy, cute, puffy cheek thigh babies. They are defined as a weight of more than 4,000 to 4,500 grams. So your 4,000 grams is around 8 pounds, 13 ounces. Some of the other things that can occur with moms being pregnant with macrosomic babies and being diabetic is she may have issues during the delivery that may cause her to have a C-section. This baby is big, baby cannot descend correctly or properly and cannot be delivered vaginally. Babies also are at risk for a shoulder dystocia, which we'll talk about later on down the line. It also says that moms who are diabetic are at greater risk for preeclampsia. The other thing that develops during the third trimester with these moms is polyhydramnios or hydramnios. Remember, this term is where she has excess fluid or amniotic fluid. We know with diabetic patients they have the potential to become ketone acidosis. This increases in the second and third trimester for mom. One of the things that can occur for baby to diabetic moms or gestational diabetic moms is babies have a higher incidence of hypoglycemia at birth. This is influenced based on mom's ability to control her blood sugar during the last half of her pregnancy and how it's maintained or handled during labor and birth. The way that we can test to see if mom has gestational diabetes or if she is diabetic is always the glycohemoglobin, A1C. We talked about that in NUR 226. Where we want these mom sugars to be are a little different than what is a normal glucose level. So make sure that you look at table 11-3, and it's on page 273. We're going to talk a little bit about insulin therapy. Most of these moms are prescribed Humalog or Novolog. Remember, both of these insulins are the rapid, or I like to call them super rapid, super fast insulins. They can be put on oral hypoglycemics. They typically use glyburide. They can use metformin, but most of the time you see glyburide used if they're going to do an oral agent. There is a nice chart on page 11, table 11-4, page 275 in your textbook. And that just goes over the different insulins, just kind of as a review. It's not something that I want you guys to memorize for mother baby. It is, however, something that you guys need to make sure you're aware of for clinical, and you're going to need to know it in med-surg. So just keep that tucked away. One of the other things I want to go over is when we're taking care of patients who are diabetic and you're giving them insulin and you're doing education and you're doing teaching, we need to know how to treat someone if they become hypoglycemic. We know that if they become hypoglycemic, there's a lot of different things that can happen to them. They become diaphoretic, pale, dizzy, confused, lethargic. So in your textbook, there's patient teaching on page 277. There's a little text box that gives you some idea of saying, okay, if your blood glucose is less than 60, you need 15 grams of some kind of fast sugar. That's to initially get the sugar up. Remember, in order to maintain your sugar, you need a protein in that body. So you can't just give them a bunch of sugary drinks and think that they will maintain their sugar. When we're testing mom and testing her blood sugars, we also have to consider we have two patients that we're taking care of. The other patient we have to take care of is baby. One of the ways they monitor baby is starting at 32 weeks. Mom gets a non-stress test done. We will talk about non-stress tests, I think, in probably a week or so. So we'll talk more about the non-stress test and what that actually means. But this is a way right now to evaluate baby's well-being. All right, we're still continuing on intrapartum care for moms with diabetes. We're going to talk about active labor, and I'll define active labor more in depth in the next couple of chapters. But mom is actively in labor. She is getting ready to have her baby, and her glucose falls below 70. So usually what will happen, she will need an infusion, and she will be giving 5% dextrose. So the moms who come in and they are diabetic or gestational diabetic, they're monitoring those glucose levels very closely during labor and delivery, during the delivery of the baby, and throughout actually the whole labor process. Remember, regular insulin is the only insulin that can be given IV. They do usually hang the regular insulin in a drip. It is titrated, and blood glucose is checked every hour, and then it's titrated to try to keep the blood glucose around 140. Postpartums, we just talked about when mom delivers the baby, her actual need for insulin decreases. Postpartum complications for these moms, though, include hemorrhage, infection, and eclampsia or preeclampsia.